Hey guys, Jake here with Med School Bootcamp. Welcome to our chapter on male pathology. We're going to start out by talking about the various testicular disorders of male pathology. Then we're going to move on to talking about some disorders of the penis as well as the prostate. So stay tuned, it's going to be a really fun chapter, and let's get busy. Alright guys, let's get busy talking about cryptorchidism and testicular torsion. These are both going to be testicular pathologies of our younger male patients. However, cryptorchidism is going to occur in our patients that are infants and toddlers, and it's going to be a chronic condition, whereas testicular torsion is more likely to occur in adolescent males, and it tends to have an acute presentation. So let's start out by talking about cryptorchidism, which is going to be caused by abnormal descent of the testicles into the scrotum. So let's start out by talking about some normal physiology here. So the testicles actually start their development in the retroperitoneal cavity. So they develop back here in the retroperitoneum, and then over the course of 3 to 6 months at the beginning of a male's life, they are going to descend into the scrotum. So they take a path down here into the scrotum, and that's where they're going to be for the rest of the patient's life. And this path actually goes through the inguinal canal, and it is guided by a structure called the processus vaginalis, which is an outpouching of the peritoneum. So in normal development, we expect the testicles to descend into the scrotum within 3 to 6 months of age, where they will remain for the rest of the male's life. Now, what happens in our cryptorchidism is that we have some sort of error along this descent, which I'm noting with these red X's. So somewhere along this pathway, a testicle can get trapped and it fails to descend all the way into the scrotum. And this can lead to complications because testicles are very temperature sensitive. And you can imagine that in the area of the retroperitoneum or within the inguinal canal, temperatures can be up to 2 to 3 degrees warmer than out here in the scrotum, which hangs away from the body. And so this can lead to pathology down the road, and this is why cryptorchidism is a pathological defect. So let's review the pathophysiology here. The testicles fail to descend into the scrotum, and increased temperature in the retroperitoneum or the inguinal canal is going to lead to impaired testicular function. And I want to mention that the impaired testicular function is due to the fact that Sertoli cells are very temperature sensitive. So I'm going to put this in red here because the high temperatures are going to inhibit proper Sertoli cell function, whereas our Leydig cells are going to be largely unaffected. They are not as affected by high temperatures as the Sertoli cells are. So let's talk about some risk factors for our patients with cryptorchidism. There's going to be an increased risk with prematurity or low birth weight. So that's going to be something you're going to be looking for in a vignette. And then the presentation is going to be absence of one or both testicles in the scrotum. So we expect to see both testicles in the scrotum by age 3 to 6 months. If there is absence of one or more, then we're going to have a suspicion for cryptorchidism and we're going to need to intervene. So let's talk about some diagnostics that we can use for identifying cryptorchidism aside from physical exam. So on labs, we would expect decreased sperm count and decreased inhibin. And it's going to be our Sertoli cells that are responsible for generating sperm and also producing inhibin. And inhibin is an important feedback molecule, so it is basically an indicator of how well Sertoli cells are functioning. And so if we have decreased levels of inhibin feeding back to the pituitary is going to be like, yo, testicles, you need to start making more sperm. And so they're going to start pushing out a lot more FSH. Additionally, they pump out more LH as well because testosterone is helpful for the maturation of sperm. So we can expect to see increased FSH and increased LH levels, and this is due to the fact that we have no feedback from inhibin on the pituitary. Additionally, we can see some changes in the amount of testosterone produced. So in unilateral cryptorchidism, we expect normal testosterone levels. However, in bilateral cryptorchidism, we can expect to see decreased levels of testosterone. And this just has to do with whether one or two testicles has descended into the scrotum. In terms of using ultrasound to diagnose this, what we'd expect to see is the location of a testicle either in the retroperitoneum or the inguinal canal using our ultrasound. In terms of the management of our cryptorchidism, this is going to be managed sometime between 6 months and 2 years of age. So we can give an infant up until 6 months for the testicle to descend into the scrotum. that is considered a normal timeline. However, if by 6 months we have failure of descent of the testicle, we need to do something about it. And the way that this is managed is going to be surgically. And essentially, we're going to do surgical replacement. So we're going to go harvest the testicle either from the retroperitoneum or the inguinal canal, and we're going to surgically place it into the scrotum where it belongs. And this process is called orchiopexy. And the reason why orchiopexy is important is because patients with cryptorchidism are at risk for infertility because the heat causes impaired sperm production, and also the increased heat on the Sertoli cells can lead to cancerous change. So there's an increased risk of testicular cancer in patients with cryptorchidism. So like I said, cryptorchidism is going to usually resolve spontaneously by 3 to 6 months, but if not, we're going to use orchiopexy to properly place the testicle into the scrotum, and this operation should occur sometime between 6 months and 2 years of age. So now that we've talked about cryptorchidism, this is going to allow us to transition into talking about testicular torsion. So testicular torsion, as opposed to cryptorchidism, is going to be an acute presentation, and it's going to more likely occur in our adolescent males. And essentially in testicular torsion, we have rotation of a testicle around its spermatocord. So let's talk a little bit about the anatomy here. So our spermatocord is what I'm outlining here in purple, and it is containing vascular structures, the arterial and venous supply of the testicle, as well as the tubular transport system of sperm back into the urethra. And what happens in testicular torsion is we get a rotation of the testicle around its own spermatocord, very similar to what we expect in ovarian torsion. It's analogous to the female pathology of ovarian torsion that we talked about previously. And what happens is when this torsion occurs, we get blood supply that is cut off to the testicle. So we have absent arterial supply and failed venous drainage. And so this is going to lead to a testicle that is starved of blood and can lead to a necrotic testicle. And this is going to be a reproductive emergency that needs to be managed with surgery. So let's just review our pathophysiology here. It's going to be rotation of the testicle around the spermatocord, leading to testicular necrosis. Now, there's a reason why certain patients are more at risk for testicular torsion, and it all relates back to our processus vaginalis. And we talked about this as an outpouching of the peritoneum that's going to guide the testicle down into the scrotum during development. Now, the processus vaginalis is going to be cemented to the posterior wall and become a structure called the tunica vaginalis, and its job is to hold the testicle in place within the scrotum. However, sometimes the tunica vaginalis does not fuse properly. So if we were to look here, I'm going to kind of highlight in blue, the tunica vaginalis should ride here along the posterior aspect of the testicle and hold it in place. However, sometimes the tunica vaginalis might only attach at a superior portion of the testicle and not hold it in place properly, and this predisposes people to testicular torsion. And this anatomical defect we refer to as the bell clapper deformity, and it's basically a horizontally aligned testicle, and what we would expect to see is instead of a testicle with a vertical lie like we have here in this diagram, the testicle is going to be sitting in the scrotum in this horizontal position, and it's way more likely to rotate on its own axis when it is in this orientation, leading to testicular torsion. With an understanding of this pathophysiology, it makes sense that males aged 12 to 18 are more affected by torsion, and this is because their testicles are growing, so they're getting a lot larger, so there's a lot more mass to allow to rotate around its own axis, and these patients tend to be very active, so they're moving around, they're bumping, they're playing sports, and this allows the testicle to have opportunities to rotate a lot more. So a classic vignette is going to be a 12 or 13-year-old male who's playing basketball, might get elbowed in the scrotum, and now all of a sudden is complaining of severe testicular pain. So we see this in males 12 to 18 years old, plus or minus groin trauma. This can happen at any age, but this is the classic age in which we expect to see it on testing. Our presentation is going to be that acute and severe testicular pain. We're going to see a high riding testicle with an absent cremasteric reflex. So let's talk a little bit what it means to have a high riding testicle. So in a high riding testicle, I'm going to highlight an orange testicular structure here in a horizontal lie, and it's going to be living a little bit higher in the scrotum than the opposite testicle, which is going to be normally a little bit lower and hanging in a vertical lie. This is going to put you on high alert for testicular torsion. Additionally, these patients with torsion are going to have an absent cremasteric reflex. And in the cremasteric reflex, if you're to stroke along the inner thigh of a patient, you expect their testicle to rise up within the scrotum like a few millimeters. So when you stroke the thigh, you expect the cremasteric muscle to contract and it's going to lift the scrotum up slightly within the testicle. In patients with torsion, this does not happen. They have an absent cremasteric reflex. This is an incredibly high yield physical exam finding and something to be on the lookout for when they are describing testicular torsion on exam day. In a neonate, we might expect to see a firm blue unilateral scrotal mass. This is because they have a necrotic testicle. It is not getting blood supply. It is cyanotic. And this patient cannot communicate that their testicle hurts. All they can do is cry. They may be clutching their abdomen. They may have nausea and vomiting. And so when it comes to a neonate or a toddler who is nonverbal, we're going to be looking for a blue testicular mass as a sign of testicular torsion. Additionally, I want to talk about something called Pren sign. So testicular torsion is going to have negative Pren sign. And Pren sign is a way that we identify epididymitis. And Pren sign is manual elevation. So you actually take your hand and you lift the testicle up. And in positive Pren sign, manual lifting of the testicle will relieve a patient's pain. However, in testicular torsion, Pren sign is not effective, so even if you manually lift the testicle, the patient will still be in pain. This is a great way to differentiate epididymitis from testicular torsion. Additionally, epididymitis tends to be a little bit more subacute, whereas testicular torsion is acute. It's like boom, as soon as that testicle torses on its own supply of blood, you're going to start having acute, really strong pain. So, like I said, no relief of pain with manual elevation of testicle. This is negative Pren sign. We expect Pren sign to be positive in epididymitis. In addition to our testicular pain, our patients can present with nausea, vomiting, and abdominal pain. And then if we were to put an ultrasound on a patient with testicular torsion, we would expect absence of Doppler flow. So we know that the blood flow is supposed to be coming down here through the spermatic cord. However, if the testicle has torsed around its own blood supply, there will be no Doppler flow on ultrasound. So we expect to see an ultrasound with Doppler flow showing absence of testicular blood flow, and this is going to lead to the necrotic testicle. And you can imagine that the testicle cannot survive long without blood flow, so this is going to be an urgent surgical reproductive emergency. In a patient that you suspect torsion, you need to get immediate surgical consultation in order to manually detorse the testicle. And so the process for doing this is going to be a bilateral orchiopexy. So even though you only have one testicle that may be torsed, it's important that surgically you go into the scrotum and you fix both testicles to the posterior wall of the scrotum, because it's likely that this person has a tunica vaginalis error, which we talked about previously here with this little light blue dot, not properly cementing the testicle in place. And so the surgeons are going to go in there and they're going to manually fix the testicle in a vertical lie to the posterior wall of the scrotum, so that way there's no chance of them ever torsing again. And this is going to be an immediate fix, and these patients will go on to have normal reproduction. They will have no further problems with testicular torsion after a well-performed orchiopexy. Now, orchiopexy needs to happen within 6 hours. If you cannot get to a surgeon within 6 hours to perform orchiopexy, then it's okay to try manual detorsion that is non-surgical. And the way that this is done is it's called the opening of a book technique. So essentially what you're going to do is you're going to grab both testicles and you're going to rotate them laterally as if you're opening a book, and it's hoping that you are able to manually detorse the testicles and get them out of that twisted orientation and resupply the blood. Now, this is only a temporizing measure. All patients are going to need surgical orchiopexy, but this can hopefully resupply blood and avoid necrotic tissue within the testicle and loss of fertility. And so this is going to be only a temporizing measure. Ideally, orchiopexy happens within 6 hours. If not, then you can try manually detorsing the testicle. In terms of our differential for testicular torsion, we talked about epididymitis and how we can differentiate this with positive Pren sign, as well as the fact that epididymitis is going to be subacute and testicular torsion is going to be more acute. And then another thing on the differential is going to be simple testicular trauma. So let's go back to our 12-year-old patient who got elbowed in the groin. This is going to be a form of testicular trauma. If this patient were to come in with testicular pain and get an ultrasound of their testicle that showed Doppler flow, we would be less concerned for torsion and be like, you probably just got elbowed in the testicle and that's why your testicle hurts. However, if that same patient had the ultrasound that showed absence of Doppler flow, signifying no blood flow to the testicle, that's a patient you're going to be concerned about testicular torsion. So I hope you guys enjoyed this video on testicular pathology of our younger patients. Can't wait to see you guys in the next video. Bye!